I am here back at Bio International, and I'm really excited. This is the last day I'm here, but maybe I saved the best for last for the interviews. So, Kurt, why don't you do a quick introduction of yourself? You can take this.
Yeah, Kurt Tamaru. So I'm the founder and CEO of Guardiant Health. Guardiant Health is a virtual care company. We help patients who suffer from chronic illness or disease, and they need more interaction and care, clinical care. And we do that through virtual means. We wrap our clinical team around that patient to supplement their care in addition to their brick and mortar care on the ground. And then we provide technology, things like data through sensors, biometric type devices, survey data, other means of communication through digital. And we aggregate that information to trend it and understand if that patient is changes in their baseline, changes in the condition are occurring. So it's a very passive way of staying in touch with a patient without being kind of in their face all the time and not interrupting their lifestyle, but being there to support them and help them. So we can be proactive, reach out, and be more effective in our care and be there when people need us.
So, as part of coming to Bio, I signed up as media, which I was telling you, Kurt, and I was looking at a list of various speakers, and I was so excited to attend your session today, and then, which many of you out there listening will understand, after my very long day that started at 7:30 a.m. with the patient group breakfast ending at 9:30 with a dinner with UCB Pharmaceuticals, I was done and I slept for 12 hours. So unfortunately I missed it, but Kurt said he would be happy to just sort of give a little bit of a recap of the session and where you played in that. I would really appreciate just a little summary.
Yeah, and so I was asked to speak on a panel around AI and data regards to personalized medicine and specifically the approach in drug development and pharma development, which is very important in autoimmune disease. As you know, a lot of biologics and new drugs coming out. My role in that discussion was as a clinical care organization that looks at a lot of different data points outside of typical medical data points. So things like lab data, x-rays, that's all, standard data. We look at other data points, what I call soft data. So we look at things like symptom, behavior, response, how am I feeling, emotion, social data, a lot of things that actually can impact someone's care that in traditional medicine, we never really incorporate into our thought about, treatment planning or, adherence or other things. We always used to, medicine didn't work and we prescribed it, someone wouldn't take it. We say, oh, it's because of side effects. Well, maybe those side effects were more pronounced because of the environment or conditions in which that patient has to take that medicine and it's not the right choice, or the conditions, they need to be aware that conditions have to be different for them to be able to take that medicine. So that's where that information that we gather as a clinical care organization that's very digital oriented comes into play in terms of, well, if you could do that for that type of care, you could do that in things like drug development and analysis of, hey, is this new drug on the market? It's out in the marketplace. We want to understand better how people are responding to it, under what conditions they respond better. Are there certain soft data points, lifestyle data points, other things that we should start looking at to say, beyond just my condition, my drug, are there other things we should be looking at that can help get a better response and outcome for that patient?
Okay. And this is one of the things, a hot topic, if you will, at our organization at AiArthritis, of this idea of whole person care. There is not a one-size-fits-all treatment for any of us. And we also, while it is recommended to have the earliest intervention possible, often with the use of some type of pharmaceutical for those with moderate to severe disease. There are people that have mild onset and they are able to feel remission in some sense without that. But research shows for those with the moderate to severe, which is the most of us, earliest intervention with some kind of pharmacologic intervention is ideal, because if the inflammation goes awry, then we develop comorbidities. And that's where the specialists happen. There's a whole team. It's not just our rheumatologist anymore. It's our cardiologist. It's an immunologist in some cases. There's neurologist. The list goes on and on. Eye involvement and everything else. So it is about the last I saw, which was recent here, a couple months ago, about approximately 70% of us have comorbidities. So there is a need for integrative health team management. And I saw on your website as I was looking that you have something that connects, or was I reading that right, to manage with the whole integrative team?
We do.
So let me ask you about that.
Yeah, so I love I agree with you. The whole thought of whole person care and individual care is very important to our model. So patients who suffer from chronic illness or chronic disease, I will say a patient who has diabetes or a patient who has heart failure has maybe comorbidities or other conditions that go along with it. Because of their disease progression, some of that is maybe separate, but it contributes to their disease issue. And you have to understand the patient at that deep level. So when I used to work on the insurance side, we used to see claims data on patients and say, oh, you're a heart failure patient by claims data. A heart failure patient is not necessarily a heart failure patient. So you look at all those different patients and they all have different comorbidities. They have different contributors to their condition and their care. So we love the model of treating the whole person, not just the condition. And I've seen many of these types of programs come out that are very condition specific, and I think they fall short because they're not able to manage the other issues that might be contributing. They might not be directly related because of the condition, but they contribute to it. And if you can't manage all of those, you can't help them with that primary issue. In terms of our platform, we have to look at different data sources that may come our way. Social data, survey data with the patient. We may be talking to a patient's caregiver or family members. We'd be looking at data around mood, emotionality. We look at support structure. We look at activity. So we look at a lot of these other data points and how do we make sense of that data in relation to clinical care and outcome and symptoms. So we have to collide that data in a way that we can sort it out. So we have what's called a NEST platform. It's a ability to navigate, engage, stratify, and treat patients, and to do it on a large scale, but do it on a very personalized level. And then deeper down is what we call our dynamic care plan process, which is a process where we actually personalize the care plan based on your issues, on your thinking, on your perception, on your goals of care, your desires. So we really personalize that plan around you because we believe that's the way to be most successful, because really the goal here is to get you where you want to be. Right? It's not me as a physician where I want you to be or where I think you should be. It's where you need to be and where you think you can get to, and helping you to do that. So that's what our platform does. It helps drive that type of support. You know, when you go to a regular doctor's office, you don't have that typical type of support behind you. You go to the doctor's office periodically, you tell them what's happening, they reevaluate at that point in time, and then maybe they change or pivot. When you have a progressing disease, you don't have time to waste. Time is your enemy because that's damage to your body. That's chronic inflammation that's settling in and causing end organ damage. And so our goal is to stay on top of things on a daily, weekly basis and get you to a better place sooner rather than wait between office visits.
Now I'm going to have more. Now the can has been opened and many things are coming into my head. So first, I just want to, for the audience, take the opportunity, if you've listened to our show before or followed the organization, we really separate the words precision medicine and personalized medicine. That term does still overlap. I'm carrying a bag that says, it says precision, but I thought it said personalized. But I went to a personalized medicine conference a couple weeks ago. But in our terminology, when we talk, we separate them. So precision being more of the science, the biomarkers, your blood markers, it's something very scientific. Whereas personalized is a lot what you were explaining, Kurt. It's the experience, it's needs, it's individualized therapy, whether that is pharmacologic or not. It is social determinants. There's a lot of things that lifestyle.
Yeah, you're right. A lot of what I talked about is that personalized side of medicine, which is behavior driven. But there is a precision component to what we see with digitalizing care like this. So everything we do sits in a digitalized environment. Correspondence, notes, lab data, other data that we're collecting as physician caring for you or with the other physicians who are caring with you. Because that's all digitalized and we're mixing it with these other data points, there are some ways we can apply philosophies of science and precision medicine to say, what are the right treatment options best for this individual based on these not just biomarkers, but maybe environmental issues, symptom side effects, comorbid conditions. And we can be much more accurate in terms of therapies that we apply and get it right first time rather than kind of this trial and error.
So my first follow-up question then is, all right, I have a primary care physician, I have a rheumatologist, I have an existing team. But I look at your website, I hear what you have to do, and I think, wow, that's something of interest to me. How would somebody even go about that? I mean, do you have your own doctors? Would we give up our doctors? How does this even work if somebody like me would like to get involved?
Yeah, so we believe that healthcare. Most people have some kind of hopefully coverage under healthcare. So we try to negotiate with payers of healthcare, Medicare being the biggest one, Medicare Advantage plans in this population. So we deal with older adults. So most of them are covered under Medicare or Medicare Advantage. If someone has a chronic condition, often we find is you need a lot of interaction with your healthcare. And the current system of care is not designed to provide that constant interaction for you. It's incentivized by having to come into an office or location. It's incentivized by more procedures being done. And so often little questions that need to get answered may not get answered. In our model, we believe that continuous interactive care helps with people who have a lot of issues, questions that need to be answered over time. And to be able to do that in an office visit is not doable. COVID was a great example of when you shut down the office access, anyone who had any kind of chronic illness or condition that needed constant care were left helpless. There were no options available to them. And we see our ability to work with these patients and their existing doctors. So we don't want to alienate the doctors. We need personal care, physical care is still needed. But often things can be done virtually. So we like to wrap ourselves around that patient and their specialist or their primary care or whoever's involved in their care and work with them. Currently today, if you're in a regular medical office and you have patients who are severely ill or have chronic illness, you can maybe manage 200, maybe 500 at most on the current model of care. If you were to take this virtual model, lay it on top of practice to enable that doctor's practice to care for more, that doctor potentially could see 2,000, 3,000 patients. Think about the access, the expansion of access to care that we just created. We've just, quadrupled the capacity of the healthcare delivery system to meet the needs of these people, these patients.
So in saying that, you touched on Medicare and Medicaid, which was great to know because we do have an audience with a lot of that. And just to clarify, this is U.S. based. You're not international, correct? Okay, just making sure. Okay, so my last question, I guess, would be: you talk a lot about the data, and I know for our organization, we have just launched a new data bank under shout out for National Data Bank for Rheumatic Diseases. So if we wanted to do something with your company, how would that work? I mean, is all of the data that you're collecting from patient communities, it's yours to keep? Is it shared? Is there anything that we could ever collaborate together utilizing our data bank and possibly do something within this autoinflammatory community?
Yeah, so I'm shaking my head here, yes, for those who can't see it. But yes, we believe in collaboration. And the problem in healthcare has been, and it's a little concerning that a lot of people are starting to look at data and monetizing data for economic reasons. We really believe that data needs to be more collaborative. The thought that the data should be the patient's and should travel with the patient. And that we build a database around our patients, not around health delivery systems or around a doctor's office. So definitely believe there's ability to take all the information you're gathering from patients who experience a lot of symptoms, have a lot of input around their conditions that is not really collected. Some of this might be soft data, but it's valuable data. Yeah. It's very important information that if you're treating patients with autoimmune disease, you should know, you should be able to incorporate that in your joint decision making with that patient. And so I would love to be able to the idea of taking data like that from that you might have or other expertise or specialties might have and being able to bring that into a shared platform where now we can use that data and that information for patient care, direct patient care.
Well, that's great. And then something about AiArthritis in particular, we also since everything is based on communication, we like to take that would be called quantitative data. So you've got, hard numbers, hard facts, and then we take qualitative, which is communication where we're talking one-on-one, collecting but collecting information. And so we would then add qualitative data to that. So the stories, how this experience is helping, that type of information, because those are important for public policy, for moving needles. And so it's sort of when we're talking about whole person care, it's also whole experience. So we just believe in looking at some stuff from research as it's going to be able to affect access and public policy. So that's sort of, I guess, the cherry on the top that I'd add to it. But Kurt, it's been absolutely fabulous talking to you. Is there anything else that you wanted to add or just some closing remarks?
I see this space that we're in virtual care as being a way to really start to democratize the healthcare. It's sad to say that many people are limited to their degree of care based on where they live. And I think this virtual, digitalized world of care, being able to push it out in that world, has a lot of opportunity to expand access, knowledge, better treatment, better care for the masses. And so I think this is the future of healthcare.
I agree, 100%. So, well, it's been absolutely fabulous talking to you, and we'll talk again soon, I hope.
Definitely. Thank you.
All right, thank you.